Sorry, we're live where and we're YouTube and outside. The man is outside. He's outside.
Seven minutes more till we hit. Okay, the call. This one. You have to start. The light is okay. You have to start. The light is okay. Where is Debbie? What's the time? She wants to bring 10:53. Okay, have 7 minutes to go. What's the time? She wants to bring you too. Ooh.
Hi, good morning, everybody. Welcome to today's webinar, which was to be a very interesting webinar. Okay, so we are live on YouTube, Facebook, Instagram, and on Zoom. I am Dr. Favor Audrey Grace, and the topic for today is dizziness and benign paroxysmal positional vertigo. Okay. So today I'll take hold on this discussion to know what dizziness is all about. But also to know the types of dizziness, also to know what kind of All right, good morning, everyone. We're sorry for the break in transmission. Okay, so just going to start all over again. Welcome to today's webinar. We are live on YouTube, Facebook, Instagram, and on Zoom. I am Dr. Grace, and today we'll be talking about dizziness and benign paroxysmal positional vertigo. I'm sure everyone is wondering, what is this? The ambiguous meaning. Okay, so let's just dive into it. Okay, so if you're looking at my slide right now, we have the outline. Okay, so our take home today will be the difference between dizziness and vertigo, types of dizziness, what is benign paroxysmal positional vertigo, and how can BPPV, which is benign paroxysmal positional vertigo, how can it be managed? Now, as a way of introduction, dizziness is a more subjective or vague symptom referring to a sense of disorientation, motion of an environment, or lightheadedness. Now, every one of us has experienced dizziness at one point or the other in our lives. It's either as kids or as an adult. It could come when you're sick or when you're dehydrated. Now, growing up, we used to play this game where we turn around, we spin around multiple times, and we feel like the room is rotating. Yeah, that's what we say. Okay, now, so that is a sense of a type of dizziness called vertigo. So we'll still go into that proper. Now, dizziness is one of the most important single symptoms with a negative effect on old age. Like the elderly people, it could lead to a lot of complications like falls. We're going to talk about that later. Now, the best way to ask a patient, or when you, as a patient, walks into the clinic to meet me and has a complaint, and you start talking about dizziness. Now, with the different types of dizziness, you may not be able to explain, but with your symptoms, I'll be able to diagnose what is actually wrong with you. Now, when I want to assess or when I want to treat you, and I start asking what kind of dizziness you feel, you may not be able to explain. So the best thing is when you come into the clinic to meet me or to meet any of our doctors, you can start by saying, oh, I feel dizzy, I feel weakness, or I have visual difficulties or anxiety. Now, these are things that can come up and bring about dizziness. So it will help us track down the kind of dizziness you have and give you a correct diagnosis. Now, dizziness are of 4 types. We have the vertigo, we have disequilibrium, lightheadedness, and pre-syncope. Now, with the symptoms you already explained, we will stand a better chance to tell you this is the kind of dizziness that you feel at the moment. Now, the types of dizziness, vertigo. So vertigo is a strong sense of motion or spinning. Now, the example I gave before, as kids, when we spin around while playing, and we feel like the room is rotating or the world is rotating around us. Now, that is a sense of what dizziness looks like. So vertigo looks like. Now, vertigo could pose as a mark or a sign of a greater problem. It could be an ear infection, it could be a sickness. So it's best that when you come into the clinic, you explain to us what you feel. Now, we'll be asking you a series of questions following up your symptoms. So it will give us a better chance to assess you properly. Now, disequilibrium, that's a feeling of off balance or unsteadiness or a wobbly feeling. Now, it could predispose you to falls. You feel very unsteady when you walk. It could happen more in older patients or people who are sick. Now, lightheadedness is this woozy or disconnection from environment. You feel like you're going to faint. It could happen out of dehydration, especially when one hasn't been eaten. You could feel lightheadedness and you come under the umbrella of I am feeling dizzy. So now we can better explain ourselves when we say we feel dizzy. So we can now tell anybody around us, oh, I feel lightheaded because I have not taken enough water or I have not eaten enough for the day. Now, the other type of dizziness is pre-syncope. Now, some of us feel like, oh, I'm about to faint. Yes, you're about to faint, but you're not fainting yet. Now, this can go on for like hours. It could go on for minutes, but it's longer. Now, you're at the verge of falling into unconsciousness or blacking out, but not getting there. Okay, so you feel that way. You feel that way like you're going to black out. Sounds are muffled, you cannot connect with your environment, but you're still, it's very uncomfortable. People who go through this will tell you that it's a very uncomfortable feeling, like they don't have charge of themselves. They don't know how to go about it. They can't even help themselves. Now, so this is a type of dizziness. Now, causes of dizziness. This cardiovascular system, when a patient has stroke, patients could come down with dizziness. In a case where there is reduced blood flow to the brain, there is neurological dysfunction in a sickness like multiple sclerosis, vision dysfunction, like the optic nerve issues, cataract, any condition that predisposes you, puts you in a condition where you can't see properly, like there's visual impairments, will actually lead to dizziness too. Now you have the psychogenic dizziness. So it's documented, research was carried out and found out that people with anxiety disorder tend to feel dizzy because the more you feel anxious, the more dizzy you get. Okay, we have the cervicogenic dizziness, which could result from VBI, vertebral basilar insufficiency. Now, it could happen when you have tightness of the muscles of the neck, which could occlude the artery going to the brain. It will reduce blood flow. Now, the blood carries oxygen to the brain. Now, it will reduce blood flow from the brain and would actually predispose you to feeling dizzy, any kind of dizziness actually. Now, the most important one that we'll be actually dwelling on today will be the vestibular system disorder. Now, this can come about maybe due to head trauma, maybe you're involved in an accident or a fall. It could actually be due to degeneration, like in older patients, infection, or BPPV, which we'll be dwelling on properly. So now it's vertigo. So what is vertigo? We've explained what vertigo is like or what it feels like. So it's an illusion of movements. Now the movement is not actually happening, but you just feel like the room is spinning around, or I am actually spinning when nothing is actually happening. So it's like the brain is having a mixed signal from both ears. Now, vertigo is the perception of motion in the absence of motion. So it can be described as a sensation of swaying, tilting, spinning, or feeling unbalanced. Now, vertigo can be of two origins. It could be peripheral, meaning that it's not coming from the brain, and it could be central, which means that it's coming from the brain. Now, benign paroxysmal positional vertigo trauma. So, what is benign paroxysmal positional vertigo? Now, it's the most common type of vertigo, accounting for over half of cases of vertigo. Now, benign means that it is non-life-threatening, so you cannot die from BPPV. Rather, what will happen is that you'll be predisposed to conditions which could put you in harm's way, like falls. Okay, then paroxysmal means that it is sudden and it's brief. So it lasts for 30 seconds to 1 minute. It doesn't last the whole day, and it's positional, meaning that it's the movement of the head that predisposes you to having this condition. Now, vertigo is the movement or the spinning or swaying or rocking feeling that you have. Now, the vestibular system. So when we talk about the vestibular system, we're talking about the ear, the systems of hearing. Now, the ear, if we're looking at the slide, we have the diagram showing the outer ear, the middle ear, and the inner ear. The outer ear, that's where we see outside, we see the ear canals, we see the cartilage, we see the earlobe, everything is outside, so that's the external or the outer ear. Then the middle ear, that's where you have the eardrum, and you have the small bones of the ear called the malleus, prepuce, and stapes. Now, we'll be dwelling more on the inner ear. Now, the inner ear houses the semicircular canal and the cochlea. The vestibular nerve and the cochlear nerve is also housed in the inner ear. So, looking at the slide now, so I'll be explaining with the diagram on the slide. So on the slide, we have three, following the mouse, okay? So we have three circles, which are called the semicircular canals. Now, the semicircular canals are placed at 90 degrees to each other. We have the anterior semicircular canal, the posterior and horizontal semicircular canal. And this houses a fluid called the endolymph. Now, the endolymph feels like a honey-like substance. It has the consistency of honey. At the bottom or the base of this semicircular canal, we have a swelling, which is called the ampulla. In the ampulla, you have the crystal in it, or the cupula. Then after the ampulla, you have a part called the utricle, which I will be explaining what happens in each one of them. Now, in the semicircular canal, like I said earlier, we have the endolymph. Now, the endolymph is a fluid. When it displaces, it triggers the hair cells in the ampulla, telling them that, oh, the head is making movement in respect to gravity. So that is why when you turn your head or you walk, you don't feel like you're going to fall. But in BPP, this would be off, and we'll be getting to that very soon. This could be off, which would lead to the feeling of feeling like you're going to fall, or feeling like the room is spinning around. Now, in the ampulla, that's where you have the cupula. Now, the cupula houses little hair cells, they are polarized hair cells, and have crystals around the calcium crystals. Now, how does BPP come about? How BPP comes about is by two ways. Okay, we have the cupulolithiasis. Now, this is when the calcium crystals can also be called the otoconia, when it adheres to the cupula. Now, earlier when I said the cupula is found at the base, inside the ampulla of the semicircular canal, okay? Now, it's a gelatinous mass that has the same density as the endolymph in the semicircular canal. Now, in most cases, this crystal could migrate from the utricle and move into the ampulla and get attached to the cupula. The cupula houses the polarized hair cells, which tends to trigger the brain, the nerves, and send a signal to the brain, telling the brain that the head is moving in a space. Okay? Now, when I tilt my head this way, and I have BPPV, because of the crystals that are attached to the cupula or the hair cells, it makes the brain think that I am falling over when I am not, which will bring about the spinning that we feel. Okay. Now, the second type of classification of BPPV is the canalithiasis, which is when the otoconia or the crystals are free floating. Now, it migrates from the utricle, passes the ampulla, It doesn't attach to the cupula, it just moves straight into the semicircular canal. Now, when I make movement, it flows with the endolymph. So that's why in BPP, the vertigo doesn't last for so long, because when you make the movement, the endolymph flows and settles. So that point where it settles, you stop feeling the vertigo. But at the period where the endolymph is moving or flowing, that's when you feel vertigo. Okay, so the pathophysiology, two types, the canalitariasis and the pupilloliterasis, which I've earlier explained. The one is when the crystal flows in the endolymph in the semicircular canal, while the other is when the crystals are attached to the cupula in the ampulla, bringing about the vertigo. Now, types of BPP. So earlier on, I said we have three semicircular canals. We have the anterior, the posterior, and the horizontal. Now, you as a person may not be able to identify the type of BPP you feel, except you come to the clinic and we have to assess you. Now, we can assess you and find out the kind of BPP you have, depending on the kind of eye movements you experience. So one thing that patients with BPP will have is what we call nystagmus, which is an involuntary rapid movement of the eye. So depending on the kind of BPP you have, it will show by the way the eye rotates or moves. Now, if you have the anterior BPPV, it will cause the eye to jump up and down. So now, if I'm doing my diagnosis and I or maybe I'm doing my diagnosis and I move you in a direction that I need to move you to, and I notice that your eye is going up and down rapidly, then I will be saying that you have anterior BPPV. Or posteriorly, if the eye rotates towards the affected ear. So most times, patients would come down with unilateral BPPV happening in only one ear, but there's also a possibility of having BPPV happen at the same time in 2 ears, or it could also reoccur even after it's been treated. Now, the horizontal BPPV, the eye moves in a left and right movement towards the affected side. So let's take the example. This is the ear that is affected, and maybe I made a movement this way, and I have my eye going this way towards the affected ear. So that's how it happens. Now, what helps us to make head movements is vestibular reflexes. So there are two vestibular reflexes. We have the vestibular ocular reflex. Now, when I'm watching a television, let's take the example of television, or you're using your phone, and someone calls your attention to something, but you don't really want to take your eyes away from what you're watching. Now, I'm looking at the camera, but I am looking in this direction, so my eye is still here, and I still feel normal. I still have balance. Now, that's as a result of the vestibular ocular reflex being intact. Now, when this reflex is not intact, it could lead to vertigo in the patient. It could lead to any type of dizziness in the patient. So it would help in angular acceleration of the head. Now, the second one is the vestibulospinal reflex. Now, this helps in movements. The way that you walk, the way you run, and you don't feel like you're going to fall over is as a result of this reflex. Now, it keeps your body balanced. So when this is up, that's when the patient starts feeling like I'm going to fall over. There's this instability. You feel like you're needing a walking aid to use. So the vestibular system, the semicircular canals are responsible for the except the semicircular canals. They are responsible for the linear movement, help you to walk around and carry out your daily activities. Now, triggers what could trigger BPPV? If a patient has BPPV, for example, right now, and you actually do not know what could trigger. So this is like a point at what could actually trigger BPPV for a patient. Now, rolling over in bed, in lie, patient wants to turn over because you cannot lie in one position throughout the night. So you have to roll over to avoid things to trigger BPPV. You have bending forward. So it's going to prevent or limit your daily activities. I will not be able to wash, I will not be able to pick things from the floor. Yeah, even when you're in a car and it's a jerking movement, it could trigger vertigo. Lying down or reclining or standing up quickly will actually predispose you to having the episode of vertigo. So these are the triggers of. So modifiers, so they could be changed in barometric pressure. So patients may feel symptoms of BPPV approximately like 2 to 3 days before it rains or it snows. Well, given that there's increased pressure or reduced pressure in the inner ear, so it could also enable the migration of calcium crystals from the utricle or the ampulla into the semicircular canal. The lack of sleep will actually lead to feeling and also bring down. So your balance system, the balance system will help in gaze stability, and orientation. So these are things that you need for your day-to-day activity. If you're running, if you're trying to look at something, if you're even playing around as a child or as an adult. Okay, so this is what the vestibular system or the balance system can actually do for you. Now, there are 3 systems that could help in keeping you balanced. It's the visual system, the vestibular system, and the proprioceptive system. Now, vestibular system disorder. We have head trauma, like I earlier said. If you have an accident, you're involved in an accident, whiplash or concussion, there's vestibular system degeneration with older patients. So this degeneration, there could be movements of the little bones in the ear, which could actually predispose a patient to BPPV. Okay, so we have vestibular neuritis or labyrinthitis and infection to the ear. We have benign paroxysmal positional vertigo, which is also a disorder to the vestibular system. Now, the endolymphatic hydros. Now, when I was talking about the inner ear in the semicircular canal, I said it houses the endolymph. Now, when this endolymph is more, the volume is more than it's supposed to be. That's a condition known as Meniere's disease, which is the primary cause of endolymphatic hydros. So there is increased amount of endolymph here, which could also be a disorder to the vestibular system. We have ototoxicity, barotrauma, and acoustic neuroma, which is tumor in the ear, could actually predispose you to this. Now, the signs and symptoms of vestibular disorder, we have nystagmus. We have nystagmus, where I talked about the eye movement, the rapid eye movements. Okay, we have vertigo, there's dizziness, there's instability, and compromised gait stability too. Now, the etiology, or what we know as causes, it most commonly it's idiopathic. That means it has no known origin. It could just happen, and that is the most common. Then it could also be as a degeneration in older patients too. We have head injury. This is more common in people less than 50 years of age. Prior otologic surgeries, like surgeries to the ear. We have vestibular neuritis infection. We have the Meniere's disease and migraines. So this is the etiology for BPPV. Now, epidemiology. Now, we have a female to male ratio being 3:1. That means females are more likely to experience BPPV than males. Now, it has an occurrence of, there's a recurrence of BPPV at a rate of 37 to 50%. Now, 2.7 times more likely to develop in patients with anxiety. Earlier on I said something about patients that have anxiety disorder could be predisposed to PPPV. Okay, so this is where it comes into play. There could be unilateral posterior canal involvement, which is most common, and we see it in 90% of cases. The unilateral horizontal canal affects 5 to 15% of BPPV diagnosis. Okay, then the anterior canal is really small. The percentage is really small, which is 1 to 2, so it's the least common. And the lifetime prevalence is 2.4%, which is really small. Now, the risk factors: sex, female. Now, with the female gender, when a patient undergoes, gets to postmenopausal age, yes, the person could start experiencing BPPV. And another age, the risk factor is age, which is more than 60 years of age. Now, low vitamin D has been attributed to a risk factor for BPPV, where there is reduced metabolism of calcium in the ear. Now, in the ear, we have the calcium crystals. So when there is a reduced metabolism of calcium crystals, the calcium generally in the body, it will predispose the patient to BPPV. And also, reduced metabolism of calcium in the body could also lead to osteopenia, osteoporosis. But in women, it could be as a result of reduced estrogen. So that was when I was talking about postmenopausal age. So once a woman gets menopause, a lot of hormones starts reducing in the body. So one of the hormones which will definitely reduce is the estrogen, and estrogen will definitely predispose a woman to having BPPV. Now, surgical procedures such as cochlear implants could also put you at a risk of having BPPV and also infection, any infection to the ear or surrounding structures in the ear. Clinical presentation. Now, this is the one that matters most to us. As a patient, when you walk into the clinic, when I ask you your symptoms, or I look at you, or carry out my test, I'm supposed to see things like an episodic vertigo, nystagmus, nausea or vomiting, visual disturbance, risk of fall, and depression. Now, we'll be asking ourselves, why is depression coming under a clinical presentation? If I find it difficult working, or I find it difficult watching television or following movements, I may not be eager to go for a party. Let's say my friend is celebrating a birthday today, and I want to wear these very lovely clothes. And I know that when I get to this party, I'm going to meet a lot of people, I'm going to do a lot of walking around. But recently, I have been experiencing vertigo. I've been feeling like I'm going to fall over. I may not be able to go. Now, this happens for a period of time. And your friends start asking you, oh, why have we not been seeing you? Where have you been? And you're saying, no, I feel this way. I feel like I'm going to fall over and all this. And maybe gradually your friends stop coming around, thinking that you're just joking around. Okay. Now that's where depression starts coming in, because you start feeling like, oh, the things I used to do, I can't do them no more. You start feeling like you're being cut off from the world. Now that's where we start looking at you. So when you come into the clinic to see us, we're going to give you a questionnaire to know if you are actually depressed. So by so doing, we'll find a way to help you better. Now, the idea of you coming into the clinic is for you to get better, for you to return back to your daily activity, for you to have a better quality of life. The essence of all this. Now, the diagnosis. So if you come into the clinic, we're going to carry out some tests. We have the distal pipe positional testing, which is for the posterior canal. Now, if you have the type of BPPV, which is the posterior BPPV, test. Why the limb and go is for the horizontal canal. That is when it's only happening in one ear. That is the best test that can be done. Now, there are other tests that can be done, like head shape, the auditometry. You can run an MRI to know if maybe a bone is displaced in the ear. If you have a CT scan, maybe in a case where you have stroke, a hemorrhagic stroke, that could be done to know what is actually going on. You can have blood test, complete blood count should be checked. Okay, we have the video nystagmography. We have the balance and rates to be checked. We have the vestibular function will be checked. Orthostatic balance will be checked. Now, orthostatic is it comes about when you just move on from lying to sitting and standing immediately. Now, if a patient has been lying for a while, it's not proper that the patient gets up immediately. Now, as the patient gets gradually, for some time, we get the person in sitting, we allow the person to rest for a while, then we can bring the person up in standing. Okay. Okay, sorry about that again. Complication. Okay, so the B in BPPV means benign, which is non-life threatening. Okay, but there are complications that can threaten the life or put you in harm's way, which is something like fracture, which is as a result of falls. Okay, so the fractures you could experience in this condition would be Collins fracture when you fall on an outstretched hand, or a hip fracture. It could be dislocation of the hip. It could be a traumatic brain injury, maybe in cases of hemorrhagic stroke or concussion, and depression. Okay, so we are all about preserving our mental health. Now, the outcome measures. Now, what are outcome measures? Outcome measures are tools that can be used in diagnosis and in identifying or knowing the prognosis of a condition. Now, when you come into the clinic and you're being assessed, this will be used. Then subsequently, in your treatment sessions, it will be used as a means of reviewing you to know whether you're improving or you're regressing. Now, the list of outcome measures that can be used, you have the dizziness handicap inventory, you have the dynamic gait index, clinical tests of sensory interaction imbalance, activity-specific balance confidence scale, vestibular disorder activities of daily living skill. Now, another questionnaire that can be used is a fear avoidance questionnaire when the patient keeps complaining of falling or a withdrawal from activities simply because the person feels like he's going to fall over. So, like, there's a fear of falls. Now, in subjective assessment, what I will be doing for you is that the first thing you as a patient can do for me as your physiotherapist is to have a dizziness diary. Now, what do I mean by dizziness diary? Now, when a patient starts experiencing dizziness in quotes, now we've talked about the different types of dizziness. So we stand a better chance to explain exactly how you feel. So you're going to tell me the type of dizziness. So you're going to write in this dizziness diary, maybe day one, the type of dizziness or vertigo you feel. You're going to also check the duration of the dizziness or vertigo that you experience. How long does it last? Does it last a minute? Does it last for 5 minutes? Does it last for the whole day or even 1 week? As the case may be, whatever you feel, that's what you're going to write down. Now, you're going to also tell us the factors that increases your sense of vertigo or dizziness. Then you're also going to write down the accompanying symptoms like fear. Now, do you feel nausea? Is there any stagnance? To explain all these things. Do you feel a sense of vertigo? You're going to write down all your symptoms. So this will help us to assess you better and give a proper diagnosis. Okay, so in the management, the first management is the Eppes maneuver. Okay, so I'll be calling my model to come and help. Okay, sorry about that. I won't be able to show you the Okay. So I will be able to show you the management, given that there's okay. Okay, so for those that are on the live stream on Instagram, Facebook, and YouTube, you will be able to see this. Sorry for the inconvenience for those on Zoom. Okay, so the Eplis maneuver, the patient is going to lie down. Okay. First things first, what the patient is going to do is to turn the head in at 45 degrees. Now, if you turn the head at 45 degrees, approximately, then I'm going to lean out over the pillow like this. Okay, so this is what she is going to do. Now, a patient that has BPPV will definitely have the circles. Before I do this, or before you do this, you must have come into the clinic and you've been assessed to know the type of BPPV that you have. So you can't just start doing this at home. Now, with this, after 30 seconds, you count for 30 seconds, then the patient is going to turn the body at 90 degrees this way. So when doing this, then she's now going to turn her head into the bed this way and hold for another 30 seconds. So by the end of this 30 seconds, she's going to bring down her leg and get up very fast. So now this is going to be repeated like 4 to 5 times every day. Okay, so that's for the Ellis maneuver. Now, another exercise that can be given to a patient. Now, this exercise is the cultural toxic exercise. It's going to help in releasing the tight muscles on the head or the neck. Okay, so it's going to help in releasing that and also help in your visual. Okay, your eye will be able to follow objects approximately. So it's like a vestibular rehabilitation exercise. So these are things that we will actually be able to do. Okay, so the first one is a head cycle, which will be done 10 times. So the first 10 times, you're going to rotate the head at 360 degrees. Your eyes like this. Okay, so she's going to do this 10 times with the eyes open. So the eyes is going to be open as she's doing this. Okay, then after doing that for 10 times, she will now close her eyes. Close your eye and also repeat the same thing. Good. All right. So that's the way it's being done. Now the second exercise is the visual tracking. Now, the visual tracking, you would have to hold a plain card. So we'll be using this as our plain card today. Now, before you start this exercise, the patient must be sitting, like she is already sitting. Please do not do it in standing. Okay, so the patient must be sitting when it's done because you don't want the patient falling or you don't want yourself to be on the floor. Okay, so I'm going to be holding this in front of the patient. Then I would expect her to rotate her head looking this way, but still maintaining eye contact with this paper. Okay, so let's do this way. Okay, and come back. So look this way and come back. So this is going to be repeated like 4 times. Okay, so you have the card in front of you. Now, if you as a patient, you're doing this exercise and your hand begins to pain you, you can place the seat in front of, let's say, a fridge and use a magnet to hold the card on the fridge. Okay, so when it's placed there, so what you're simply going to do is to focus on this card while you take your head 90 degrees, still maintaining eye contact, and in the other direction, maintaining eye contact. So it's going to help in visual focus. Okay, we have the target exercise. Now, in this target exercise, we won't be using the papers, but I'll be using objects. Now, these objects will be kept at 90 degrees on both sides. So for my patient, we're going to have the object kept at 90 degrees here and 90 degrees here. So it's like 180 degrees. So she's going to turn and look in this direction, then look in this direction and come back to midline. So let's start. Okay, so look in this direction and turn this way and come back to midline. So first, you're going to do this 4 times. You're starting from the right and going to the left. So you do that 4 times. Then after the 4th time, you now start from the left and go to the right and come back to the line. So that's the way this target exercise is done. Now, the sacral exercise is when you hold these 2 cards at 30 degrees. Now, I will be holding this approximately 30 degrees to my patient. Okay, so I will need her to switch hand movements from this card to the other card. Okay, so this is the way it's going to be done. Switching from here to here, here, and here. So that's the way it's supposed to be done for the patient. Now, another exercise that can be given as a home program to the patient. Now the patient is seated already. So what we're going to do is to just tilt her head in 45 degrees, approximately 45 degrees. So she's going to put her hands together this way, good, and she's going to tilt 45 degrees. Now, when she's this way, she's now going to fall over very quickly. All these exercises are done quickly. Then she's going to maintain this position for 30 seconds. So by so doing, at the end of 30 seconds, the nystagmus should be over. Then she sits up very quickly again. And she's going to repeat it on the other direction. Now, how to do this exercise? You've learned the motion or how it's being done, but you're going to repeat it 4 times this way and 4 times this way. So that's the way the exercise is to be done. Now, you cannot carry out this exercise on your own till you are clinically diagnosed. Okay, so after the diagnosis, we will give you exercises that should be done in the clinic before we teach you properly and also monitor you before you can do this exercise on your own at home. Now, habitual techniques. So, things to avoid when doing these exercises or during treatments. Avoid quick spins or movements that will provoke vertigo. Sleeping in a semi-recumbent position. So you have to prop yourself up on pillows. So if anything that is going to keep you lying flat on your back should be avoided. So you use stacks of pillows to keep yourself upright for 2 nights after the treatment has been commenced. Then avoid lying on the affected side. So if it's my right ear that is affected, I won't be lying on my right side. Rather, I will be lying on my left side until treatment is over. Then try to keep the head upright during the day. Now you finished your exercise or you finished from a physiotherapy session, you are advised to keep your head upright as you go about your daily activities. Nothing that is going to help make you bending forward or looking downwards and avoid spine activities, like I said. Then after being conservative for 1 week, that's avoiding all these things that we said, the precautions to take, then you now start placing your head in those specific directions or carrying out those motions that give you vertigo. It will enable you to know if you are getting better or if your treatment has to be changed. So these are the things that you as a patient, you're going to keep in check and get back to us when your treatment has been started. Now, prevention of falls. A complication of BPPV is fall. So there are certain things that you should be doing to prevent yourself from falling. Number 1, lying still in a quiet, dark room to reduce the spinning. Now, if you start feeling a sense of vertigo, you should actually find a place to lie down, calm till the experience or the episode of vertigo has passed. Then move your head carefully and slowly during daily activity. No rapid head movements. Okay? Sit down straight away when you start feeling dizzy. So maybe you start feeling dizzy, do not push yourself because you could experience a fall. Just find somewhere and sit till the episode of vertigo has passed. Now turn on the lights at night when you wake up. So at night, maybe you feel like you need to use the restroom. You have to turn on the lights so that you can actually see where you are going to and have a sense of your environment to avoid falls. Then use a walking stick if you feel like you have a risk of falling almost all the time. Okay, so use a walking stick. Okay, then use of handrails in the bedroom. So you could actually situate handrails around the house. Climbing up the stairs, you should use the handrail as you're climbing into the bath in your bedroom. Try to use a handrail. Now get out of the bed slowly and sit on the edge of the bed for a while before you stand up to avoid what we mentioned earlier on, the orthostatic hydropressure. Okay. So you have to sit up gradually and rest for a while before you stand up. Now try to relax in cases where you have an anxiety disorder. Try to relax and avoid stress because these two things could actually make your vertigo worse or trigger vertigo episode. Now avoid bending down to pick things. Okay, so you bend with your knee instead of bending over this way. You bend with your knee to pick up whatever you need to pick up. At the same time, keeping your head straight. Now avoid extending the neck backwards. So nothing will take your head back. Your head is supposed to be straight. So in case you're trying to reach for something, okay, you can hold something to help you bring that down instead of climbing up somewhere because it would actually fall. And we're also trying to avoid you taking your head backwards. So the best thing or the best approach is to have assistance, have someone around to help you in this condition. Then do not try to drive, especially when you've been experiencing vertigo. Do not drive, do not operate any machine or climb ladders. I mean, these things could actually be detrimental to your life. So you can try as much as possible to avoid these things. So these are the preventions of falls or precautions that you could take when you experience vertigo or DPP. Okay, thank you very much. Okay. All right. So is there any question after listening to the presentation? Does anyone have any question, anything that needs to be clarified? Anybody with any question? Okay. All right. Still nobody with any question. I can. Okay.
Yeah, I said, thank you, Dr. Taylor.
All right.
So please, can you explain how anxiety causes dizziness?
Okay. When someone is anxious, okay, so now you're panting, you actually don't have a sense of your own well-being, okay, so you could actually trip over things Now, if you already have BPPV or vertigo, now your body you're not relaxed. There's constant head movements, your head is moving around, okay? So it still dislodges the crystals from the actual position where they're supposed to be, which is the utricle, and moving it into the semicircular canal. So this is a way anxiety could actually lead to you having episodes of, it can actually increase the frequency at which you experience vertigo. Okay. Okay, all right. So someone asked, can we have highlight review of the presentation? Okay, good. Now, when I was starting the presentation, I said what will be taking hold from this presentation is to know difference between dizziness and vertigo, and to actually know how to treat BPPV, what BPPV is all about. Okay, so dizziness is that sense where you feel like you're falling, you're experiencing symptoms of lightheadedness or vertigo or pre-syncope or even disequilibrium. So like there's a presence of fall. There is also lightheadedness due to dehydration. Okay, now dizziness is like an umbrella word for these types of dizziness. So you coming into the clinic and telling me you have dizziness, or explaining to somebody around you that you have dizziness, is not cutting it out. You have to actually explain. Do you feel nausea? Do you have nystagmus? Do you have vertigo? So this falls under what dizziness is all about. Now, also differentiating the types of dizziness, which I have mentioned, we have lightheadedness, there's disequilibrium, there's pre-syncope, and it's vertigo. So we've been dwelling more on vertigo today. Now, we talked about how to manage this. But the first way of managing it is by actually walking into a clinic and getting your diagnosis straight. Because you can have any of the types of dizziness. It could be anterior, it could be posterior, and it could be horizontal. Okay, so now when you come into the clinic and you are actually diagnosed of having a type of BPPV, then you will stand a better chance to actually tell you this is the type of exercise you could do. So like I earlier mentioned, we have the Elpis maneuver, we have the curl prone coccyx exercises, which will help in eye movements and also help to relax the muscles of the neck. Then we also have the Bradford's exercises, which could actually help in taking back the calcium crystals to the original position where they are supposed to be. Now, you cannot carry this out on your own, as I have said, because you have to be trained properly and you have to be educated on what and what not to do before you start doing this. Okay? Now, someone has another question. Said, good afternoon, everyone. Though I joined late, okay, no problem. I met a lady who said vertigo is. How possible is that, and what can be done to reassure her? Okay. Now, vertigo cannot be a normal sickness. There must be something triggering your vertigo, actually. Okay. So the first thing is to actually assure her that she will be fine, because there is actually a way to take care of that. It could be BPPV that is triggering her vertigo. She could have an ear infection. There could have been a trauma to the head leading to that. So the best thing, the best line of management is to actually get this patient to a clinic to see a doctor so that tests can be carried out, because I mean, she can't be living her life having vertigo all the time. We've talked about the complications of vertigo. So there's a risk of fall. You could actually harm yourself. Maybe you could actually have an episode of vertigo and fall into a ditch or fire. You will not even know how to help yourself. To actually help this patient is by reassuring her first that she can be treated. Yes, she can be treated. And to actually help her get into the clinic for her to be properly assessed, diagnosed, and treated. Thank you. Does anyone have any question again? Any other question? Yeah. Okay. Any other question? Okay, I can't see any other person asking any question or typing. So I take it that we understood the presentation today and we know how best to help family members or anyone around us. If the person starts complaining or mentioning that they have dizziness. So first thing, you're going to ask the person, what are your symptoms? So that's the best way to help the person. Then you stand a better chance to actually know if this person has BPPV or any of the kinds of dizziness, then you know that the best thing you can do for the patient is to actually tell this patient to come into the clinic for assessment. Thank you very much. And do have a beautiful day. Thank you. Thank you. We didn't stop the video. I've stopped. I just